Welcome to the Deep Dive. Today we're really focusing in on a critical topic, respiratory failure.
hmm
We've got some excellent revision notes here, and our mission is pretty clear. Break this down so it's easy to understand and remember.
Absolutely.
Let's-
Especially for revision.
Exactly. We'll cover everything, the definition, causes, right through to complications, all aimed at making it stick. Ready to jump in.
Let's do it. So respiratory failure, at its core, it just means the lungs aren't doing their job properly. The gas exchange part.
Getting oxygen in, CO2 out.
Precisely. So the fundamental definition is inadequate gas exchange. This leads to either low oxygen in the arterial blood, that's a PaO₂, below 8 kilopascals, or KPI, or high carbon dioxide levels.
Okay, so that O2-CO2 balance is key, and I know there are different types, aren't there?
Yes. Generally, we talk about two main types. First is hypoxaemic respiratory failure, type 1.
Type 1, okay.
And the big thing here is low oxygen, that PaO₂, less than 8 kpi. But importantly, the carbon dioxide level, the PaCO₂, is usually normal, or sometimes even a bit low. There's a little mnemonic that can help. Low O2, norm low CO2, type 1.
Low O2, type 1. Got it. So that's low oxygen being the main problem. What about the other type?
That's hypercapnic respiratory failure, or type 2. Here, the defining feature is high carbon dioxide, so a PaCO₂ greater than 6 kPa.
High CO2.
Right. And often, though not always, these patients also have low oxygen, so that PaCO₂ less than 8 kPa might still be present.
Okay, so high CO2 is the hallmark, but low O2 can come along too.
Exactly. And the mnemonic follows: high GHCO2, type 2O.
High GHCO2, type 2O. Simple, but effective. So type 1, oxygen problem. Type 2, CO2 problem, maybe with low oxygen. Now, the notes also mention categories. Acute, chronic.
Yeah, that's about the timing, the onset. Acute respiratory failure is sudden, often in someone who didn't have major lung issues before.
Right, out of the blue almost.
Sort of. Then you have acute-on-chronic. That's when someone with an existing chronic lung condition gets suddenly worse. Their baseline function deteriorates quickly.
Like a COPD patient having a bad flare-up.
Exactly. And finally, there's chronic respiratory failure. This develops gradually, over days, weeks, sometimes longer, usually because of a long-term lung disease.
Okay, that clarifies the different ways it can present. Now let's get into the why. The etiology. What actually causes these?
Yeah, the causes. It really helps to think about them separately for type 1 and type 2. It makes remembering them easier.
Okay, so let's start with type 1, the hypoxemic one.
Right. For type 1, think about things that mess up the lung's ability to get oxygen into the blood. So COPD is a big one. Pneumonia, obviously. Pulmonary edema, fluid in the lungs. Pulmonary-fibrosis, that's lung scarring. Asthma, particularly bad attacks. A pneumothorax, or collapsed lung. Then there are blood flow issues like pulmonary embolism.
A clot in the lung.
Yes.
Yeah.
And pulmonary hypertension. Even things like cyanoticcongenital heart disease. Other causes. Bronchiectasis, ARDS, acute respiratory distress syndrome.
That's a serious one.
Very. Also, respiratory illnesses linked to HIV infection. Structural things like kyphoscoliosis, a curved spine affecting breathing, and even obesity.
Wow, that's quite a list for type 1. Any tips for keeping those organized?
Yeah, try grouping them mentally. You've got diseases affecting the lung tissue itself, like fibrosis, edema, ARDS, pneumonia. Then airway diseases like COPD, asthma, bronchiectasis, structural problems, pneumothorax, kyphoscoliosis, vascular problems, the embolism, hypertension. And then the heart condition is kind of its own category, obesity too.
That definitely helps break it down. Lung tissue, airways, structure, blood flow. Okay. What about type 2 then, the hypercapnic causes?
For type 2, there's some overlap, yes, but the focus shifts. It's more about things that impair ventilation, the actual mechanics of breathing and getting CO2 out.
So not just the lungs, but the whole breathing system.
Exactly. COPD and severe asthma are still on the list, definitely. But key causes also include things affecting breathing control or muscle power, like a drug overdose, say opioids, or poisoning that suppresses the drive to breathe. Neuromuscular diseases are important here. Myasthenia gravis, polyneuropathy, even poliomyelitis. Other muscle disorders too. Head and neck injuries can affect mechanics. Obesity again, restricting lung movement.
Interesting how obesity pops up in both.
Yes, it can affect oxygenation and ventilation. Pulmonary edema and ARDS can also cause type 2. And don't forget hypothyroidism. That can slow everything down, including breathing.
It's fascinating how conditions like COPD or edema can lead to either type, depending on, I guess, how exactly they affect the patient.
Precisely. It depends on the dominant physiological problem at that time. So think about who's more likely to get respiratory failure. Let's talk risk factors.
Okay, who's most vulnerable? The notes mention patient characteristics and then medication or substance use.
Yeah, so patient characteristics.
And so,
Well, advanced age is a big one. Unfortunately, things tend to work less well as we get older.
sure.
Having pre-existing lung disease, COPD,
Hmm.
interstitial lung disease, that obviously puts you at much higher risk. Smoking is a major factor, no surprise there. Obesity, as we mentioned. Also, having a weakened immune system makes you prone to infections that can trigger it. And certain other conditions like heart failure or kidney failure can contribute. These are kind of underlying weaknesses.
So often it's someone with these background issues already. What about the medication and substance side of things?
Key things there are sedative or opioid use. They can directly suppress breathing.
Right, like we mentioned for type 2 causes.
Exactly. Prolonged mechanical ventilation itself can sometimes paradoxically contribute to or complicate things later. And long-term exposure to environmental pollutants can damage the lungs, making them more susceptible down the line.
Okay, so let's try a quick recall question for you listening. Which of these is a risk factor for respiratory failure? A, regular exercise, B, advanced age, C, low body mass index, or D, vegetarian diet?
And the answer there would be,
Advanced age. Right. Okay, let's dig into the pathophysiology now. What's actually going wrong at the physiological level for these two types?
okay, so for hypoxemic failure,
Yeah.
type 1, the PaO₂ drops below that 8 kPa mark. A major mechanism is something called ventilation-perfusion mismatch, VQ mismatch.
VQ mismatch. Heard of it.
Yeah, basically some parts of the lung might be getting air, but not enough blood flow to pick up the oxygen. Or they might have good blood flow, but not enough air getting in. It's inefficient.
Like a disconnect.
Exactly. Another key mechanism is shunting. This is where blood passes through the lung circulation without actually getting oxygenated at all. Both VQ mismatch and shunting led to impaired gas exchange and ultimately tissue hypoxia. The body's tissues aren't getting enough oxygen.
That analogy of a faulty connection really helps. Okay, so what about hypercapnic, type 2, the CO2 buildup one?
Right. Type 2 is primarily about the body not being able to get rid of CO2 effectively.
Yeah.
So the PaCO₂ climbs above 6 kPa. The main reason is alveolar hypoventilation.
Hypoventilation, so under breathing.
Essentially, yes. Breathing is too slow or too shallow to blow off the CO2 that the body is producing, so it builds up in the blood.
And that leads to...
That leads to the elevated CO2 levels and consequently respiratory acidosis. The blood becomes too acidic because of the excess CO2. Think of it like the exhaust system being blocked.
Good analogy. So different primary problems, oxygen uptake in type 1, CO2 removal in type 2, but both mess up that crucial gas balance. Now, if someone comes in breathless, confused, what else could be going on? The differential diagnosis.
Yeah, that's vital. Several conditions can look very similar. You absolutely have to consider pneumonia, pulmonary edema, whether it's the cause of the failure or just mimicking it. Pulmonary embolism, definitely. An acute exacerbation of COPD is high on the list. Congestive heart failure and various neuromuscular diseases that affect breathing muscles.
So a lot of the usual suspects in respiratory and cardiac emergencies.
Pretty much. The memory tip is just that. Think common respiratory or cardiac issues that share those symptoms, like breathlessness or confusion. Investigations are key to sorting it out.
Speaking of which, how common is respiratory failure, particularly in the UK? What's the epidemiology look like?
Well, specific UK-wide incidence data is a bit limited, actually. But we definitely know it's a major reason people get admitted to hospital.
Okay.
It's much more common in people who already have lung diseases, as you'd expect, and it's frequently seen in intensive care units. The exact numbers really vary depending on the underlying cause and the specific group being studied.
Right. So common enough to be a significant issue, especially in hospitals and for those with lung problems. Okay. How does it actually look? Clinical presentation, signs and symptoms.
The classic symptoms are severe shortness of breath, dyspnea, and rapid shallow breathing. You might see cyanosis, that bluish tinge to the lips or fingertips indicating low oxygen. Patients often feel confused, very fatigued, restless. Sometimes their level of consciousness decreases, and in the worst cases, it can lead to full respiratory arrest.
Definitely serious warning signs. How do you start figuring out the underlying cause from just seeing the patient?
A really thorough history and examination are crucial. There can be specific clues. For example, if someone tells you they wake up suddenly breathless at night, paroxysmal nocturnal dyspnoea or PND, or they can't breathe lying flat, or orthopnoea that strongly points towards pulmonary edema.
Often from heart failure, right?
Often, yes. And what signs might you actually see on examination?
Good question.
Well, the signs vary a lot depending on the cause, but commonly you'll see restlessness, confusion, a rapid heart rate, tachycardia, and cyanosis, as mentioned.
Okay.
In people with chronic low oxygen, you might see polycythemia of the body making extra red blood cells, and you need to look for signs of cor pulmonale.
That's the right heart failure due to lung problems.
Exactly. Caused by pulmonary hypertension. That might show up as an enlarged liver, hepatomegaly, or swelling in the legs and ankles, peripheral edema.
Okay, so you piece together the story and the physical signs. Then you move on to tests, right?
Yeah.
How do we confirm the diagnosis and find the cause? Investigations.
Absolutely. The single most important test, the cornerstone, is an arterial blood gas, an ABG.
The ABG, always key.
It directly measures the oxygen and CO2 in the arterial blood. It confirms the diagnosis, tells you if it's type 1 or type 2 and how severe it is. It's the key investigation.
Okay. What else?
Well, you need to find the cause. So a chest x-ray, or often a CT scan of the chest, is vital to look at the lung structure, check for pneumonia, edema, collapse, embolism, etc.
Key imaging is essential.
A full blood count, or FBC, can show anemia, which would make hypoxia worse, or polycythemia in chronic cases. Kidney and liver function tests, U&Es and LFTs, give clues about other organ involvement or potential causes, and check for complications like electrolyte problems.
Okay, so ABG confirms, imaging looks for the cause, basic bloods check overall status. Any other specific tests?
Sometimes. Serum creatine kinase and troponin I might be done to rule out a heart attack, or they could indicate muscle inflammation like myositis as a cause.
For the neuromuscular cause.
Right. Thyroid function tests, TFTs, are important if you suspect hypothyroidism causing hypercapnic failure. Spirometry can help assess underlying chronic lung disease. If a heart problem is suspected, an echocardiogram, an ultrasound of the heart, and an ECG are standard.
Echo and ECG. Makes sense.
In really complex cases, maybe where the cause isn't clear, a right heart catheterization might be done to get detailed pressures and assess heart function and fluid status. Pulmonary capillary wedge pressure measurement can specifically help differentiate cardiac versus non-cardiac pulmonary edema.
That sounds more specialized.
It is. And of course, if you suspect infection, you need microbiological studies, sputum cultures, blood cultures. Sometimes, rarely, a lung biopsy or aspirate for histopathology might be needed.
Wow, quite a range of tests depending on the situation. It really highlights the complexity. So once you've got the diagnosis, how is it managed? What's the approach?
Management really depends on whether it's acute or chronic, the cause, and how sick the patient is. Acute respiratory failure almost always means hospital admission, often straight to ICU. Some stable chronic cases might be managed at home, but acute is serious. Immediate resuscitation might be needed if they're critically unwell. But the absolute priority is always treating the underlying cause.
Right. Antibiotics for pneumonia, diuretics for edema, etc.
Exactly. Alongside that, you need to ensure they're getting enough oxygen. The goal is usually a PaO₂ of at least 60 mmHg, or oxygen sats above 90%. But big caution here in patients with chronic high CO2, like some COPD patients, giving too much oxygen can actually worsen their CO2 retention. So you need to be careful.
That's the hypoxic drive issue, right?
Sort of. It's more complex, but yes, high O2 can reduce their drive to breathe and worsen hypercapnia. And assisted ventilation is often needed, isn't it?
Oh, definitely. Assisted ventilation is often central. Mechanical ventilation intubation and a ventilator machine takes over the work of breathing. It supports gas exchange, helps lower CO2, rests the muscles, often used in severe acute hypoxaemic failure.
But weaning off can be tough.
It can be, especially in chronic cases. An alternative, particularly in certain situations, is non-invasive ventilation, or NIV.
The mask.
Yes, using a tight-fitting mask instead of a tube. NIV has been shown to improve survival and reduce complications in specific scenarios like COPD exacerbations, cardiogenic pulmonary edema, and for some immunocompromised patients. It avoids intubation.
Good option when suitable.
Then there's ECMO, extracorporeal membrane oxygenation. That's like an artificial lung outside the body, used in very severe cases, often in neonates and pediatrics, but sometimes adults too. Though NICE guidelines urge caution due to side effects.
High-level intervention.
Vary. And whenever you're supporting oxygenation, you have to think about the risks lung injury from the ventilator or oxygen itself. oxygen toxicity, maybe needing blood transfusions, effects on the heart.
Lots to balance.
And for the hypercapnia and acidosis in type 2, the main things are treating that underlying cause and using ventilation, invasive or non-invasive if needed, to help blow off the CO2.
So it's tailored, address the cause, support breathing carefully, manage the O2 and CO2. What's the outlook then? The prognosis?
It's really variable. Hugely depends on what caused it, how severe it was, how quickly treatment started, and the person's overall health.
Makes sense.
Prompt recognition and getting the right management quickly definitely improves the outcome. But severe cases, sadly, have higher risks of other organs failing, long hospital stays, and higher mortality.
And the mortality rates themselves vary.
Yeah, they depend heavily on the specific underlying cause, how fast the diagnosis was made, and how effective the treatment was for that particular patient. Early action is key.
So timely treatment is crucial. What about the potential pitfalls along the way? Complications.
Right. Complications are a big concern. They can affect pretty much any system. In the lungs themselves, you can get ARDS developing, pulmonary embolism, long-term scarring or fibrosis, and ventilator-associated problems like pneumonia, VAP.
Okay. Cardiovascular.
Carpulmonale, as we mentioned. Also low blood pressure, hypotension, irregular heartbeats, arrhythmias, and the heart not pumping effectively, reduced cardiac output.
Gastrointestinal issues.
Yeah, things like bleeding, the stomach getting distended, the bowels stopping working, ileus, and stress ulcers are all risks. Other things. Polycythemia from chronic hypoxia. Infections are a major risk, not just pneumonia, but sepsis, UTIs. The kidneys can take a hit leading to acute kidney injury, AKI, or electrolyte and acid-based problems.
Nutrition too.
Malnutrition is common, especially with long illnesses, and the mechanical ventilation itself carries risks like VAP, lung injury from pressure, barotrauma, or ventilator-induced lung injury.
So it needs really close monitoring to catch and manage these things.
Absolutely. Preventing them where possible and managing them quickly if they occur is a huge part of care. So that was a really thorough run-through of respiratory failure. I think the key takeaway for everyone listening is it's serious. It's about inadequate gas exchange. There are distinct types and many causes. And management is all about fixing the underlying problem while supporting breathing.
Exactly. Understanding those definitions, the different causes for type 1 versus type 2, and being aware of all those potential complications. That's really vital for effective learning and recall.
Definitely. And, thinking about that huge range of causes we covered, it really makes you consider how prevention strategies would have to be so different depending on the specific risk factors for type 1 or type 2 in different people. Something to mull over.
Good point.
If you want to dive even deeper into respiratory failure or other key medical topics for your revision, don't forget to check out pastthemsra.com and also freemsra.com. They're fantastic resources.
Really useful sites.
Thanks so much for joining us for this deep dive today.